Hi, good morning, everyone. So I've chosen a few cases that we've seen over the last year. I've chosen one viral, one bacterial, one fungal, and one parasite. If you've joined our ID seminars, our WIT seminars every Monday, you've probably seen these cases before. If you haven't, the QR code to join them is here. So we have an ID seminar every Mondays, 3 to 5, and we present unknown cases as well as a didactic clinical talk. So you're welcome to join us. Everybody's welcome. It's actually nationwide now. So we have about 150 to 200 people that join from across the country, microbiologists, infectious diseases specialists, the likes. So the first case I'm going to present, I'm going to go quite quickly because there's 4 cases and they're a little long. The first one is a viral case. So we had a 33-year-old female who's living with HIV and virologically suppressed on first line. She was transferred to us from Bertha with this crusted lesions on her face and scalp. And they were worried about a super infection, so they had transferred her to us for further management. The rash was described as painful, pruritic. It was associated with a headache and reduced vision on the right eye. She didn't have any introduction of new drugs or any constitutional symptoms and no travel history. On examination, she was mildly tachypneic. She had a pyrexia 37.8 degrees. And on general examination, she had multiple cervical lymph nodes with an axillary node measuring 5 by 3 centimeters and these crusted lesions on the face, which I'll shortly show to you on the next slide. She was also mildly tachypneic with stony dullness appreciated in the right lower zone, some scattered crackles bilaterally, normal cardiovascular examination. She did have a 5-centimeter hepatomegaly with a small palpable spleen, and her neurological system was otherwise intact. So these were the lesions on her face. You can see very typical crusted dermatomal distribution lesions in keeping with the zoster ophthalmicus. We were quite concerned about lid margin involvement here as well with the reduced vision on that one eye. So this was an initial chest x-ray. You can appreciate an effusion on the right, and if you can, and slightly rotated x-ray, but you can see that there's some mediastinal widening, which we were also a little bit concerned about. In terms of a blood investigation, she had a normal UNE. She had elevated ductal enzymes on her LFT, and her hematology workup was a little bit concerning. She had a white cell count of 37 that was neutrophil predominant. She had a normocytic anemia with an HB of 9.4. But then of note, the instrument-generated differential count noted other cells of 11, an absolute value of 11 here, which we were also a little bit worried about. And then a CD4 count that was 15,855, which we thought was spurious in the beginning, but it tied in very well with the case in the end. So in terms of her viral workup, her Hep studies were negative, and an HSV2 IgG and varicella zoster IgG was positive, but the rest came back negative. So our working diagnosis here was a zoster ophthalmicus infection, but we were concerned that she might have had, or she might have an underlying TB or non-tuberculous mycobacteria. We're trying to bring in this mediastinal widening, this lymphadenopathy that she had, and the respiratory symptoms as well. And the other thing we were thinking about was, could this be a lymphoma, an HIV-associated DLBCL for some reason, or could it be an HTLV1 infection, which would explain that T-cell clonality. So on her pleural fluid results, you can see it was a polymorph predominant, innumerable polys. We didn't find anything on the Gram stain and didn't culture anything. And her TB gene expert was also negative on the pleural fluid, but it was suggestive of an exudate. So in terms of the peripheral blood smear, we got hematology to have a look, and those atypical lymphocytes, or those 11% of other cells that we saw, were actually described as atypical lymphocytes with intermediate sizes and irregular nuclear bodies, highly suspicious for a hematological malignancy. So just to remind you, the TB workup so far, her urine LAM was negative. We've done a sputum, pleural fluid, and an FNA gene expert, all came back negative. And her TB culture was kicked out after 42 days, so also negative. So this was her timeline. On day 0, she had been transferred to us from Bertha. And then we had started our baseline investigations and a cyclover for her zoster infection. And then we had asked for a skin biopsy. So dermatology helped us there with the skin biopsy. And we had also ordered a bone marrow aspirate and trephine. And we consulted ophthalmology for the lid margin involvement. But on day 3, our patient changed condition. She became quite distressed respiratory-wise. So we were worried about maybe she had developed a nosocomial infection because she had been at Bertha for a while before that. Or maybe now she's got a PE. So we had escalated the antibiotics overnight. We had given her therapeutic doses of Clexane. We had asked for steroids because we were worried if that mediastinal mass was causing some compressive symptoms, maybe we might be able to relieve some of those symptoms with high doses of steroids. So we started that, and then this was our excuse to get an urgent CT of the chest. So we managed to get that, and we very quickly managed to expedite the report. And because Heme was very helpful in this case as well, they had expedited the trephine results for us. So I'm just going to play you a quick video of the CT scan, and you can see there's a large effusion on the right, and then coming up in the anterior mediastinum, you can appreciate there's this anterior mediastinal mass there. There's a cursor. Oh, you can't see the cursor. I hope everybody saw it. Okay, and then our bone marrow results had come out. In terms of the IHC, she was CD3, 20, and 30 positive. So in conjunction with the IHC and the morphological features that were seen, this was a clear-cut case of an adult T-cell leukemia secondary to an HTLV1 infection, right? So we had ordered serology. It wasn't out at this time, but based on the clear morphology, it is an HTLV1 infection until proven otherwise. So just a quick note about HTLV. It's a retrovirus of the retroviridie genus Delta retrovirus, and it causes chronic infection by integrating its DNA into somatic T cells and then causing those cells to clonally expand. There are 4 types that are described, HTLV1 to 4, and HTLV1 is associated with adult T-cell leukemia lymphoma, and 1 and 2 can be associated with HTLV-associated myelopathy, HAM, or previously it was called, I can't get it now, tropical spastic paraparesis, yes. So in terms of the pathophysiology, it's primarily transmitted through contact with body fluids. And this includes blood, breast milk, semen, and it seems to be hyperendemic among IV drug users in the North Americas and the Europe. There's a strong documentation of mother-to-child transmission, primarily through breastfeeding, and this is one of the campaigns that the WHO has initiated, either a cessation of breastfeeding in endemic areas, or to employ this freeze-thaw method of breast milk. In terms of risk factors for adult T-cell leukemia lymphoma, it's extremes of age, the male sex, a high viral load, a long duration of infection, and very interestingly, but we can't explain why, it's commonly associated with the strongyloides infection, and the strongyloides infection itself poses a risk for ATR. In terms of the treatment, I'm not going to go into much detail, but there's no vaccine available. There are a few chemotherapeutic regimens, and zidovudine together with alpha interferon in combination therapy has been recommended by many. There is also a monoclonal antibody that exists for the treatment. Okay, so case 2 is a fungal case. So this was a 43-year-old female from Zimbabwe. She moved to South Africa in 2002. In terms of her background history, she had a metabolic phenotype, but was retroreactive and suppressed on first line and denies any previous TB. So she presented with a 3-month history of this left foot ulcer that was progressing in size, but there was no weight loss, no respiratory symptoms. She had a negative pap smear in 2021, no mammogram. And then interestingly on probing, she told us that she had presented to Charlotte in 2015 with a similar presentation. She was debrided in theater, histology was done, and in fact, we managed to pick up these histology results in retrospect, but she was lost to follow-up. So in terms of her presentation, so she had initially presented to Charlotte in 2015 with this ulcer. It was debrided and she was lost to follow-up. then presented later to Edenvale Hospital in 2018. The surgeons had discharged her on dressing, so they wanted to do chemical debridement and antibiotics. But then she represented in 2023, and she was complaining that the ulcer was worsening. And those surgeons had taken her to theatre for debridement again. They sent off the histology, and the histopath was very concerned with the histology, so they actually informed ID of the case. And it so happened that I had been doing outreach at Edenvale at the time, so I was on site, and I was able to quickly run across and see this patient in the surgical ward. And then we got her transferred across to Charlotte thereafter, and then we had started treatment for her. But when she had got across here, we examined her. Examination was pretty normal, except for this large ulcerative lesion on the left foot. It was looking very clean because it had just come back from theatre post-debridement. And her blood results were essentially unremarkable. A normal USC, UNE, FBC, CRP, not very impressive. LFT is normal. Chest X-ray also nothing really to worry about there. But this was the lesion. So you can see quite this extensive ulceration on the foot. And then there's a sinus here on the plantar surface, and there's a clear connection between, again, you can't see the cursor, I'm sorry, but you can see on the third image that there's a communication between that ulcer and this one on the plantar surface. So these were the x-rays that were done, and you can see the midfoot bones. There's very, very suspicious lytic lesions there that we were also concerned about. So the next image is a close-up. I'm not sure if you can appreciate the black specks. So that's quite important. And that actually tells us what the diagnosis is even before looking at the histo. And we'll get to that now. But we had done a CT scan for her before transfer, and the CT scan showed a left foot plantar ulcerated enhancing soft tissue lesion. There were multiple lytic lesions with intra-articular extension, and obviously some surrounding cellulitic changes. So in terms of the histo, so they did see these large granules, and these large granules had interlacing hyphae, and it was PAS positive, Grocott positive. Those are two stains we use for identifying fungi. And these morphological features were in keeping with what we call a eumycetoma. So mycetoma, we very normally incorrectly refer to fungal balls or aspergillus balls in the chest as mycetoma, but that's untrue. Mycetoma, the true term, is actually an ulceration of the foot. And it's divided into two types. So you can get a eumycetoma, eu meaning true, so it's a fungal infection of the foot. And then you can get an actinomycetoma, which is a bacterial infection of the foot, right? But its definition is a chronic, progressive, destructive infection of the subcutaneous tissue that can spread to the skin, the deep tissues, and the bone. It's common in tropical and subtropical environments, and it usually follows minor trauma or penetrating injury, commonly thorn pricks. So it's usually on the foot, especially in barefoot walkers, but it can occur anywhere in the body. So as I said, eumycetoma means fungal and actinomycetoma is bacterial. So there's no real data on incidence and prevalence, but we do know that it's commonly seen in this mycetoma belt. So this is the countries that we usually see it. So you see not so much in sub-Saharan and not so much in South Africa. And in terms of the species, in terms of the fungi, so Margurella mycetomatis is the common bug that's implicated. And then you can see other fungi, but about 90% is secondary to Margurella infection. So patients will usually present with this classic triad of the subcutaneous soft tissue swelling with sinuses and grains like our patient had. And you can do serology to diagnose, although it has a very, very low sensitivity and specificity, and quite useless in endemic areas. And you can evaluate the grains. So the color of the grains can also tell you what this is. So if it's a dark black colored grain, it's usually fungal, and it's usually Margurella. And if it's if it's a white colored grain, then you think more bacterial. But very interestingly, you can actually collect the grains, smash them between a glass slide, and you can observe the hyphae under the microscope on a wet mount. So it's quite easy to diagnose. Histology isn't necessary for the diagnosis, but we managed to get a diagnosis here from the histopath. And PCR, you can use, so we do have access to an 18S rRNA PCR, which is a pan-fungal PCR. Unfortunately, we didn't get to we knew it was fungal, but we didn't get to a diagnosis for this patient because we failed to grow it in the lab. And our PCR had also failed. It was contaminated. So we got a zoo back with the results, and it wasn't really very helpful. But we do know that it's fungal, right? So in terms of treatment, for eumycetoma, we usually use the azole fungals and in combination with surgery. And in actinomycetoma, you may just get away with antimicrobial treatment without any surgical need. So for our patient, we had actually started her on itraconazole. She's still being followed up. She had multiple debridements after we had seen her. It's going to be a very long course of therapy. They take quite long to heal. Okay, I'm racing through these. I think we can, enough time, we can slow down a bit. So the third case is a bacterial case. So this was a case seen by Dr. Sharon Sunny. She was doing a 3-month stint here at Charlotte last year. So she had actually been very involved in this case. So this case is courtesy of her. So this was a 71-year-old gentleman with a 3-week history of a productive cough and excruciating back pain. He didn't have any history of vomiting, diarrhea, dysuria, skin rash, joint pain, but he was a metabolic syndrome with peripheral neuropathy and HIV negative. He denied any previous surgeries or allergies or any previous admissions to hospital. And in terms of his presentation, so he initially presented to his GP with this cough, non-specific symptoms initially, and was discharged with a week of antimicrobials, and then presented to his local hospital, Far East Rand, with worsening back pain. And he was diagnosed as having a pneumonia. And then they discharged him on more antibiotics. We're not sure what, but he was given more antimicrobials. And then he re-presented 2 days later with even worsening back pain, but he was quite ill at this point. He was diaphoretic. And the guys at Far East Rand decided to do a CT chest, and there was something very suspicious. They had contacted vascular, you'll see why now, and they had transferred him across to Charlotte. So the next day we had been consulted along with the relevant specs for this worrying CT that was seen, right? So in his initial examination, he was febrile, BP slightly up with HTTs of 18, quite ill looking. He had his bed propped up at 45 degrees because of this excruciating back pain, but normal cardiovascular exam and stony dullness that was remarkable with absent breath sounds in the right hemithorax. So he had a normal abdominal exam, normal CNS, and on MSK, there was a tendothoracic and lumbar spine in the T12 to L1, L2 region. So this was his imaging. So again, I don't have a pointer, but if you just look at the aorta and you try and follow it down, you're going to see a second shadow there.
I'll use the pointer without screens here.
Let me just, sorry. There we go. Okay, thank you. Okay, now it's not playing, Jared. So you're looking here, right? So you can see that's the aorta, and then you're going to start seeing a second shadow. So around there we go. Okay, so there was some bony involvement, which you can't appreciate here. But this is essentially mycotic para-aortic abscess. And this was the level T10 to T12. It was an associated right-sided effusion, which you can appreciate. And there was some bony extension to T11. So in terms of differentials for mycotic aneurysms, in terms of bacteria, Staph aureus, step species are common. You can also see them with Salmonella, with Treponema pallidum, mycobacteria, especially in our setting, and the gram negatives. Viruses, obviously not common for pyogenic infection. Fungi, you can see it with Candida, Aspergillus, some of the deep fungals, and obviously protozoa and helminths, again, not common with pyogenic infections of this kind, right? So we had tapped the pleural fluid. We saw 3+ neutrophils. The gene expert for TB was negative. And this is what came back. So we got Salmonella subspecies that was resistant. It was cyprosensitive, but resistant to ceftriaxone. And that we said was our diagnosis. So we managed to get it here on the pleural fluid. We didn't manage to grow it on blood, but we think that this mycotic aneurysm is all related to this Salmonella deep-seated infection. And we commonly see these kinds of infections. They usually occur in our HIV positive patients, non-typhoidal Salmonellas with deep-seated pyogenic infections. But in this case, we think that his risk factor was his poorly controlled diabetes. So in terms of your general risk factors, like I said, for mycotic aneurysms, so any arterial injury, so that could be IV drug use, any invasive monitoring, cardiac catheterization, the use of ECMO, or any infection like pneumonia, cholecystitis, UTIs, endocarditis, in fact, and any impaired immunity. This could be secondary to diabetes, chronic alcohol use, steroids, malignancy, etc. So in him, the only risk factor we could pick up was the fact that he was a poorly controlled diabetic. So in terms of the etiology of mycotic aneurysms, it can happen from direct inoculation or bacteremic seeding, contiguous infection, or even from a septic emboli. That would be in the case of infective endocarditis. And in terms of the microbiology, so Staph aureus and coagulase negative staphylococci account for the majority of cases, with the gram negatives, which would include non-typhoidal Salmonella, accounting for about 30 to 40% of the cases. So he had a multidisciplinary team involved. He was actually admitted to ICU, and because of those differentials I gave you earlier, he was started on miroamic vancomycin before we had gotten the Salmonella results. Vascular surgery had taken him in for an urgent TEVA, which is a thoracic endovascular aortic repair, and it was stented. And then cardiothoracic surgery was involved for VATS and a basal drain insertion for that right pleural effusion. And then orthospine was called in to monitor this osteomyelitis, but he wasn't for any intervention from their side. It was for medical therapy from their side. So he was seen by us together with the microbiology team in ICU, and we decided to de-escalate him to a single agent, to meropenem, and to limit, this is just to limit his exposure to fluoroquinolones, because we knew he'd need a prolonged duration of therapy. The endocrine team was helpful with his diabetes management, and then he was discharged home. He actually returned 2 weeks later for repeat imaging. He did quite well in terms of his repeat imaging. Unfortunately, I haven't been following up with his case, but he completed his course of antibiotics and responded very well. Okay, and then that takes us to the last case, the parasite case. Still time? Lots of time, great. Okay, so this case we actually presented last week in our ID meeting. She was a 46-year-old, oh, she is a 46-year-old female domestic worker. Her retro status was unknown at the initial presentation, but she had presented to Hillbrow CHC with chronic lower abdominal pain for about 6 months. But now this new presentation was because of this worsening abdominal pain, and she had an episode of vomiting that morning. She also had reported presence of hematuria, dysuria, frequency, and urgency, but didn't have any recent travel history and no recent history of any herbal medication use. She claimed to have had her last menstrual period about 3 weeks ago, but she had many episodes of vaginal discharge syndrome. So she had recurrent presentations to a local clinic, and she was syndromically managed and discharged. And she told us that she's originally from a place in Malawi called Balaka. I'll show you on the map just now, but she moved to SA many, many years ago. So this is where she's from. And then I've just pointed out that's Balaka, very close to Lake Malawi. And on examination, essentially normal vitals, no lymph nodes, no jaundice, good breath sounds bilaterally, normal cardiovascular, but she did have this suprapubic and right flank tenderness, but her abdomen was otherwise soft. So as our ED friends love to do, a POCUS was done, and they found a grade 3 hydronephrosis in the right kidney. They had inserted a transurethral catheter, and they found some rose-colored urine. And they had done a dipstick on this urine, and nitrites and leukocytes were both positive. So this is the diagnosis, intrauterine parasite. So we found that she was actually pregnant. So she was 9 weeks and 1 day pregnant. So this is not the only parasite though. So obstetrics were called. So it was also a multidisciplinary approach here. Obstetrics and urology were called, and obstetrics had done their baseline workup, and her TPA was non-reactive. HIV was reactive, so she's now newly diagnosed, RH positive. The urine lamb was done, negative. That was just to try and expedite initiation of ARVs. And then there was a suspicious cervix. So this is not an image, an actual image of a cervix. They were very careful to protect this intrauterine parasite. But this is a picture of what it looked like, right? So it was very hyperemic. I don't have a picture, unfortunately, of a normal cervix, but it doesn't look as red and inflamed as this one does, right? And if you can see, oh, well, we'll get to it now. So in terms of her initial investigations, renal function, she had an elevated creatinine of 95 for a pregnant woman. It is a little bit concerning. LFTs that were normal. She had slightly raised inflammatory markers, a PCT of 53, with essentially a normal FBC, HB on the lowish side. And in terms of her initial urine results, so she had more than 750,000 leukocytes, a very significant pyuria, erythrocytes of more than 750,000, but a mixed growth was isolated from this culture. So we were not sure how to interpret this. In terms of her timeline, so she presented to the ED, seen and admitted to urology. Urology had done their own ultrasound and confirmed this right-sided hydronephrosis, but they had deferred the nephrostomy because they were worried about this intrauterine pregnancy and the contrast that they used. They gave us a very long story, but essentially they decided not to do the nephrostomy at that time. And on day 2, she had slightly worsening renal function. Her inflammatory markers were up and the urine became a little bit more turbid. So they decided to take her in on day 3 for cystoscopy, and they had done a biopsy as well. And then contact was made with the pathologist to please have a look at this biopsy because she is pregnant and we want to get to a diagnosis quickly. So the clever urologists and obstetrics doctors were worried about bilharzia. So both had sent schistoserology to different labs on the same day. And the obstetrics were worried about it based on this hyperemic cervix that I think one of the doctors had seen before. And the urologists were worried because of the area that she had lived in, and her current presentation may have been in keeping with uroschisto. But unfortunately, both serological tests came back negative. And when we had examined, we've spun the urine down here at this lab to look for ova. We still couldn't see anything in the urine. So this is just a schematic of what they had seen while doing cystoscopy. So they did see lots of erythematous changes. What's not on this image is that they did see urethral outlet stricture, which would account for that right-sided hydronephrosis. And that was from a little bit of fibrosis around the trigone area in the bladder. And then interestingly, sandy patches were noted. So sandy patches are synonymous with schistosomiasis, right? So this was the histology. So I don't know if you can appreciate, but oh, there's the pointer. So here's multiple eggs in between the normal bladder mucosa, right? So multiple eggs. Some were viable, some aren't viable. You can't tell which eggs they are on this image because of the slice. So normally you'd be able to tell which schisto egg it is based on the presence of the lateral spines. So if it's a terminal spine, for instance, it's a schistosoma hematobium. If it's a lateral spine, then it's Mansoni. So we couldn't really tell from this image, but we know that urogenital schisto is usually secondary to schistosoma hematobium, right? So this was the report. So they were viable and degenerative schistosomal ova, and this was in keeping with urinary bladder ovocycle schistosomiasis. So the question here would be, why was her serology negative though? And there were a few reasons why. So we had actually contacted the NICD at this point to also assist us, first with evidence for managing a pregnant woman with this kind of presentation, and then second, for why this serology would be negative. This was two separate kits at two different labs. So there are a few hypotheses. We don't actually know the answer to this question. But one could be the test kit itself. So we're not sure which test kit was looking at which antigen. And we know that in areas of high endemicity, sometimes we see hybrid species, and these kits may not be able to pick up antigens based on hybrid infections. The other issue was, could this be a proson infect? Unlikely in this case, but a proson infected is usually with an antigen antibody based test. If you have an overwhelming amount of either antigen or antibody, it's going to affect the binding, and it's going to affect your test outcome. So we see this often with syphilis, and we've been actually seeing it quite increasingly with, Notando will tell you, with our crypto patients, where we are highly suspicious of cryptococcal disease, and your cryptococcal lateral flow assay comes back negative. And then when we ask the lab to repeat it in dilutions, it becomes positive. And that's because of the hook or the proson effect. So that could be in this case, but this is such a chronic infection. We wouldn't be expecting that. So could this be because of waning antibody titers because of the chronic infection? Or could it be because of the immunosuppression? She is newly diagnosed retro, she is pregnant. We weren't really sure why this was negative, but we were happy enough to get a biopsy diagnosis here. So she was diagnosed with urogenital schisto. So there is an entity called female genital schisto, but the WHO is starting to move away from that and to group this entity of urological schisto, genital schisto into urogenital schisto to raise awareness for female genital schisto, because it is a common entity. Because remember, there was a suspicious cervix that we saw here. And in fact, in high endemic areas, you can diagnose cervical schisto or female genital schisto just by looking at the cervix. So there's a pocketbook that the WHO has online, which gives you very specific images of what the cervix can look like. And this is quite helpful because in areas where you don't have access to histology or any other specialized tests, you can just make a diagnosis based on what you see. Obviously, this is given that it's endemic in the area. So she was diagnosed with urogenital schisto based on the appearance of the cervix and the histology results from the cystoscopy. We started her on ARVs. We treated her with antibiotics for whatever UTI she had. We didn't get to a diagnosis for what that precipitating event was, but she had a good response. She had signed refusal of hospital treatment. She had some social issues, but we had asked her to return for dosing of praziquantel. So that's how we treat schisto. So we treat it with praziquantel, and it is safe in pregnancy, but the WHO recommends only in the second and the third trimester. There's very poor efficacy data for first trimester, and also we're not sure of any harms that it can do in the first trimester. So we had only given her a dose in the second trimester. And it's actually in areas where it is endemic, it's recommended that all school-going children should get mass dose administration of praziquantel to prevent this from happening, along with many, many other public health interventions. But she was planned a continued outpatient obstetrics follow-up. So far, there hasn't been any Euro intervention for her, but she seems to be doing very well in her pregnancy. She's still pregnant. All right, and I think that's all our cases.